Okay, welcome to the OrthoClips podcast series. I'm Saqib Rehman, and today I'm with Dr. Yelena Bogdan, and we're going to be talking about atypical femur fractures. So let's just get into it. Dr. Bogdan, thanks for being with me.
Thank you very much for having me. I'm very happy to talk about this relatively obscure but very fun topic.
Yeah, and I know that you have a lot of interest and expertise, so I think our listeners will appreciate that. So maybe we can start right in and have you briefly describe what are atypical femur fractures. What does that mean? Maybe a little bit of background.
Yeah, so inevitably the term atypical femur fractures is related to bisphosphonates, since that's what most people associate them with, and that's one of the first misconceptions that I want to break up, because the term bisphosphonate femur fracture, it's not always associated with bisphosphonates. In fact, there are femur fractures that look exactly like these atypicals, and they occur in patients who have other bone disorders and who have never been on bisphosphonates. Likewise, there are people on bisphosphonates who never get fractures, but it is the most commonly cited link. But for the purposes of this talk, let's just call them atypicals. And so the background kind of is pretty simple. For the scourge of osteoporosis, bisphosphonates are now becoming very widely used, and they were used for a while, and then, especially out of Asia, people started having these very strange-looking femur fractures that would occur from very low-energy trauma, and they were primarily subtrochanteric, and I'll kind of explain why in a little bit later. But they didn't look like your very typical subtrochanteric femur fractures. They were occurring in younger individuals than the typical hip fractures would be, and they had a very specific appearance. They looked like they were chalk stick type of fractures. They looked like they just broke in half, and most importantly, sometimes they occurred without any trauma at all. And the connection was made pretty early on. The first case reports came out in 2005, and it became a big issue in the lay press because people started saying, oh my God, these bisphosphonates are doing something to the bones, and you're going to have a broken femur, and there was like this big hullabaloo about it. Well, I don't think anybody should be panicking, and I'll kind of talk about that a little bit, but there is certainly a connection there. So at their most basic, atypical femur fractures are a subtype of an insufficiency fracture. So it's basically an insufficiency fracture is a stress fracture that occurs in abnormal bone. So there's something unusual going on inside the bone, either as a result of the bisphosphonates or as a result of a bone disorder, but the normal remodeling process is somehow altered, and that causes these fractures to occur. So as I said, they're associated with bisphosphonates, and that is the largest risk factor, particularly with alendronate, which is also known as Fosamax. First of all, because it's very commonly used in the United States, and second, because it has the longest half-life out of all the bisphosphonates, so it can stay in the body for years. And the connection between bisphosphonates and atypical femur fractures is actually stronger than the link between smoking and lung cancer. So in at least one study, the odds ratio was 139, so for occurring if you were on bisphosphonates versus if you were not. And in terms of what they are specifically, if you want me to go into kind of like how to diagnose them or what types of patients get them, generally they're going to be a little bit younger by about a decade than your standard hip fracture. They tend to be female, also because females are more likely to be treated and to get osteoporosis, and usually there's minimal to no trauma, so sometimes they could just be standing and turn funny and their leg will snap and then they fall. They have prodromal pain, not all the time, but much of the time, so depending on what you read, about 30 to 77% of the time, they're going to have some kind of pain, and it doesn't have to be just in the area of the hip. It can be in the knee. It can even radiate to the back. So a lot of these things are missed early on until they fracture because people think it's coming from something else. And a lot of the time they're going to have contralateral findings as well. So one of the most important things I want to impart is that you want to make sure that you check the contralateral side. And then in terms of how to diagnose them, there's a very specific radiographic pattern. The American Society of Bone and Mineral Lateral Research released a list of criteria. So there's 5 major criteria. There's a couple of minor criteria, which I won't get into, but the 4 out of 5 must be present in order for it to be diagnosed. So the 5 of them are minimal to no trauma. The fracture has to start on the lateral side, and it's got to be predominantly transverse. So what I mean is on the lateral cortex, it has to be basically 90 degrees, and that's been studied. So the fracture line has to be completely straight laterally. If it's not, then it is not a bisphosphonate fracture, or it's not an atypical fracture. With a complete fracture, it has to involve both cortices and might have a medial spike, and with an incomplete fracture, it has to start laterally. If it starts medially and there's nothing laterally, again, not an atypical fracture. So that's one of the criteria. And then the next one is that it has to be non-comminuted or minimally comminuted. And the last one is that there has to be local thickening of the lateral cortex, not the whole bone, just the lateral side. So those are the 5 criteria: minimal trauma, originating laterally, complete has to involve both, and incomplete has to only involve the lateral, non-comminuted, and local thickening. So if you have 4 out of 5 of those, it's you can be pretty certain that this is an atypical fracture.
It's a great overview. I think that really is going to help the listeners understand, just to make sure they don't miss one, and that there are more than one criteria. So now that it's been 10 to 15 years since we first recognized these, where are we at least with regards to our published literature? What does the data suggest, or maybe are there any kind of clear, are there any clear recommendations from the data with regard to best management practices, with things like surgical technique, aftercare, maybe with regards to fracture prevention, because they're on medications already and they're osteoporotic. And then also you mentioned contralateral side surveillance. So what is the literature telling us?
Yeah, so there's a couple of questions that you asked, and I think they're all super important, so I'm kind of going to try and answer them one by one. So first of all, in terms of treating these fractures and managing them, if you happen to find one before it completely, so a lot of the time we don't get to these people until they fracture and they come to the emergency department, but sometimes we'll be lucky and they'll present to us before they fracture, so they'll have radiographic findings on their x-ray, or sometimes people will get an MRI or a bone scan and something will look funny and they'll send them to the orthopedic surgeon. So first of all, what do you do if it's not complete and they haven't fractured yet? So is there a role for non-operative management? The answer is yes, but most data will suggest that if they have pain, it's much better to prophylactically treat them and do prophylactic surgery, because the outcomes are much better with prophylaxis rather than trying to treat them non-operatively and then when they fracture, trying to treat them after that. But there are certain factors in which you may want to treat them non-operatively. If you have a very compliant patient who can stay off of their leg for up to 3 months, because no one quite knows how long to keep them non-weight bearing for, it's basically until the pain goes away. If the findings are minimal, if there's basically nothing on the x-ray and maybe they have a little bit of edema on their MRI, then it's not unreasonable to try and treat them non-operatively. If they don't have what's called a dreaded black line, so if you see on the x-ray or on the CAT scan, you see that a transverse line in the lateral cortex, particularly in the subtrochanteric region, because the forces there, the tensile forces are very, very strong. So if you don't see a dreaded black line, then it's reasonable to try a trial of non-operative management. But because these are so rare, and that's one of the things I want to kind of emphasize, that there's a panic over them, but the majority of people who are treated with bisphosphonates never get anything close to that. So these are still extremely rare, and most people will never get this complication. That's why it's very hard for us to really understand these fractures, because there's just not that many of them. So it's hard to know what to do with them. So there is no real standardized protocol for how long you keep them non-weight bearing. What do you put them on? Things like that. But what we do know is that if they have persistent pain, or if sometimes they can't be compliant. They say, listen, I've had patients who say, listen, I go to the gym every day. There is no way I can be off my leg for 3 months. Just fix me, and I have. But if you're going to do it non-operatively, you protect their weight bearing, usually for about 2 to 3 months. You discontinue bisphosphonates, obviously, but just discontinuing bisphosphonates may not be enough because bisphosphonates stay in the body for many, many years. So that in itself might not be the only thing that you have to do. You send them to the endocrinologist, make sure you don't have something else, and then Forteo is still very controversial, even though a lot of people use it. But like I said, the outcomes for non-operative management are not that great. They have a high risk of fracture progression, depending on what you read, anywhere from 40 to 85%, and they tend to have a longer length of stay if, let's say, you treat them prophylactically, and it's basically just like fixing a sawbone versus waiting for them to break. Then you have a bigger problem. So, and they also have a lot of the time they'll have persistent pain until you fix them prophylactically. And then for treating them prophylactically, obviously, if they have that dreaded black line I talked about, if they have intractable pain, if they have a large femoral bow, so usually this happens in the Asian population, and I think personally that's why these reports first came out of Asia, because the bow is slightly larger and the patient's the skeleton is a little bit differently shaped, particularly in women. They also have a bigger they have a bigger coronal bow. So if you have a very bowed femur with a dreaded black line, I would say prophylactically fix that because that's going to break. And if they fail, conservative management, and also if that's the patient choice. So that's kind of like how you make your decision. And then in terms of how to fix it, the mainstay I will say is cephalomedullary nailing. There are some people who believe that these fractures should be treated the way non-unions are treated, so they'll compress the heck out of them and they'll plate them, but plates have a slightly higher complication rate. So I think the first thing, the first line of defense or the first line of treatment, and certainly in prophylaxis, but definitely for treatment as well, is cephalomedullary nailing. So when you do it, there's a couple of points. Number one, always do a long nail and always protect the neck. So don't, even if these things occur in the shaft, and they can occur anywhere in the femur, they don't have to occur in just the subtrochanteric area because it really depends on where the tensile forces are the strongest. And so the bigger your femoral bow, actually, the more distal the fracture is going to be. So you can see them in the shaft. You can even see them closer toward the distal femur. So don't be tempted to do a retrograde nail and leave the neck unprotected, because I have seen femoral neck fractures occur afterwards. So just protect the entire thing, long cephalomedullary nail. If the patient has a very large coronal bow, there are special nails made for that, so pay attention to the radius of curvature of your nail. There are special smaller nails made for these patients, particularly in certain parts of the world. There's a special nail called the Cirrus nail, which is spelled S-I-R-U-S, which is a little bit, which has just has just a higher curve to it, so it's just a little bit more curved. And so if you have a very large bow, you want to be careful to make sure that when you're putting a straight nail down, you don't perforate. And then in terms of the technique, that's the other kind of most important point, is that these fractures are extremely unforgiving. So this is not your typical subtrochanteric fracture. So subtrochanteric fractures, I mean, you put the bone anywhere in the same neighborhood and it's going to heal. That is not the case with atypicals. So there was a very good study by Dr. Cho, and I think it was in the Journal of Orthopaedic Trauma, and it was called, Healing of Atypical Femur Fractures, Which Factors Predict Union. And so and they basically found that as little as 5 degrees of variation in either the coronal or the sagittal plane. So if you put it in as little as 5 degrees of varus, it's going to fail. Now, varus is never good anyway in any subtrochanteric fracture, but these are particularly unforgiving. So you want to make them as anatomic as possible. So to that point, in terms of tips, surgical techniques, I open almost every one of them. If I can't get them perfect, I will open them and provisionally plate them with like a little 2-4 or 2-7 plate and unicortical screws, and then I'll put the nail in, because you want to get them as perfect as possible. You don't have to go crazy. If you can get it closed and you can get a good reduction, you don't have to open it or scrape out the fracture site or anything like that. There's been some work out there showing that doesn't seem to work. You don't really have to bone graft it, but I mean, if you can, if you're opening it anyway, you can scrape it out and just because you're already there, but you don't have to do that if you can get it closed. So just get it perfect. however way you can, and don't distract it. So try and compress it down. And usually when you have that lateral fracture line, there's going to be a little bit of reabsorption because the body is just trying to absorb it or trying to remodel that fracture site, and it can't, and that's what creates that dreaded black line. So even if you kind of backslap the nail and try and get compression, you'll get it on the medial side. You may still have a residual gap on the lateral side, and I wouldn't worry too much about that because you can't close that down because it's not anatomic anymore. But if you can get it closed down on the three other sides, posterior, medial, and anterior, then it's very likely to heal. And it's got pretty good results. You know, there's a lot of talk about these things don't heal or they don't heal as well. They do take longer to heal. So on average, they can take as long as 11 months to heal. So people intervene early in these fractures thinking that they're going on to a non-union when in fact they're just really, really slow because the remodeling process is altered. But they actually have pretty reasonable healing rates of about 85%. So they're not as horrible as people make them out to be, because the current studies that are showing that there's more revisions in these plates, if you look at these studies carefully, the revisions are sometimes not for that fracture at all. They're not like revisions for non-union. Sometimes they're for periprosthetic fractures that occur from another fall. Sometimes the reasons for the revisions are unclear. So it's not like they're all being done for some problem that's going on with the fracture itself. But certainly you have to watch them very carefully because especially if they're not anatomic, they are very prone to delayed or non-union.
Okay. And, you kind of gave a lot of practical tips, I'm sure, from some experience dealing with these that I think a lot of surgeons who encounter them occasionally can probably incorporate in their practice. So I appreciate you giving those tips. And what
the
about?
Other thing I want to add? Oh, sorry. I think the only other thing, the other thing that I want to add is that these are not your stereotypical hip fracture patients. So they don't go to nursing homes. They actually, this is one of my studies that I did with a lot of other people in other centers. We had a big multi-center trial of these, and what we found is about 94% of them were living at home at their final follow-up. So these are young patients, relatively like physiologically young. They want to go home. They're active. These are not like they have to be differentiated from your standard hip fracture patients, so you can't really treat them. You can't treat them the same way.
That's a good point. Now, I guess as my final question before we finish, how has the medical community responded to this? Now it's been 10, 15 years. You said that these are pretty rare, but have medical practices for prophylactic treatment of osteoporosis changed specifically because of these atypical fractures, or are things pretty much the same or just changing as they normally would as newer drugs come out and modalities of treatment?
I think there's a little bit more awareness of it. Certainly now the FDA, now they recommend a drug holiday for bisphosphonates. So after about 3 to 5 years of taking them, you take a drug holiday to sort of, I think the idea is to allow the drug to clear the body and help it not build up so much that it doesn't affect the remodeling process. But bisphosphonates are just still so incredibly effective in treating osteoporosis that they are still the first-line drugs. In fact, one of the issues with Forteo is that it's not often covered by insurance and it's very expensive. But if one of the sort of tricks is that, if someone has an atypical femur fracture, by definition they have failed bisphosphonates. So you can actually try and get the insurance to cover Forteo because that is the second line drug. But I don't think there are people. I don't think people are really moving away from bisphosphonates so much as kind of just being more aware of these things. And I think to any medical colleagues that are listening, if a patient starts to suddenly complain of thigh pain or just an ache anywhere in their leg, particularly especially if it's on both sides, certainly don't hesitate to send them to an orthopedic surgeon, because that's something that if we pick it up before the patient breaks, the outcomes are so much better. And I've had several of these experiences where somebody just came in and they were within a couple of weeks, they became completely wheelchair bound because they were having so much thigh pain and they couldn't understand what was going on. And fortunately, their physician was smart and sent them to an orthopedic surgeon to try and figure it out. And they actually got sent on to me because the surgeon thought that they might have an impending atypical fracture. And sure enough, they did, and it was very distal. It was actually close to their knee replacement, and they thought that there was something wrong with the knee replacement, but it wasn't. It was right above that. There was in the distal femoral shaft, there was a little bit of a change there in the cortex, and I did a prophylactic nailing, and the change was incredible. I mean, literally on the first day after the nailing, the patient was up and walking when they had been wheelchair bound for several weeks because of this pain. So if you can catch them early, it's actually quite a life-changing procedure.
Yeah, I think it's important, and it can sometimes not be caught early, and then they come in with a fracture, but you always have that opportunity, even in those cases, to deal with the other side before it becomes a problem.
Yeah, absolutely. And so the other side definitely should be monitored. For how long, unfortunately, no one knows, because, if someone, goes back on bisphosphonates, and we just don't have the data to know that, they're just still so rare, and a lot of the time also they're mistaken for something else. So I'm sure the rates are actually probably higher than what we think, but because these are not high energy injuries, I am sure some of them are being treated kind of inadvertently as regular hip fractures by community hospitals and whoever, they're not being seen in the major trauma centers because they're minimally traumatic or sometimes atraumatic. So, who knows how many of them are really out there.
Yeah, good point. Well, I think that's a lot of great information on an important topic. Dr. Bogdan, I want to really appreciate you taking the time to speak with me, and thank you very much.
Yeah, thanks very much for having me. Thank you.